All right, so let's get started. So welcome everyone. It's time for another edition of National Journal Club. Very excited. We have the Einstein Group from Philadelphia here to present. And just before we jump into it, a couple of ground rules to just remember. Remember, we would love to hear from you. We'll pause between articles presented. So if you'd like to make comments, please raise your hand. We'll acknowledge you, or also feel free to put something into the chat. For those of you on Twitter, please use the hashtag ACMTNJC, and we'll keep that chatter going. I'm very excited about this topic today about methemoglobinemia and alternate treatments. I'd like to acknowledge our fellow presenters, Richard Chen, Alexis Cates, and Laura Roper. And their faculty mentors are David Goldberger and James Kruger. So thank you so much, folks. And with that, I will kick it away to you.
Right. Thank you very much, Dr. X, for inviting us to give Journal Club this month. We kind of rattled our heads a lot about trying to figure out, what topic to discuss. And, we came off a very interesting Poison Center consult, which brought us to this topic, which Dr. Cates is going to start the discussion talking about. But I just want to say I'm proud of my three fellows that we have here. They've worked really hard through this whole pandemic, and they've worked really hard in this presentation. So I'm going to let Alexis take it away.
All right, thank you. And yes, again, thank you for having us today. So our question regarding the presence of adulterants in the illicit drug supply was actually brought up during a recent case that we had with the CHOP Poison Control Center. So we were consulted by an ED physician in Delaware regarding a patient who had presented with what she thought was methemoglobinemia. So profound hypoxia and syncope following intramuscular use of cocaine, in addition to intravenous heroin and fentanyl. And we had not encountered this scenario in the past, especially in the absence of other known methemoglobin inducers, so we began our research. And we found that it is well known that cocaine in particular can actually be associated with methemoglobinemia, but it's usually not from the cocaine itself. It seems that it's actually from similar compounds such as benzocaine that might be diluting the pure cocaine supply. Drug suppliers may dilute cocaine with substances that tend to look similar, so sugars such as glucose, mannose, saccharose. There can also be talc, flour, boric acid, even levanosol. And then other common adulterants, including other local anesthetic agents such as lidocaine or benzocaine, pictured on the right there, which may not only look similar in its powder form, but also provide a similar numbing sensation when applied to the lips to test for purity prior to use of cocaine. So with diluted cocaine, this will then result in both a lack of purity of the substance, leading to use of more and more to achieve the desired effect, the desired high, and potential harm from the cutting agents. So in the case of benzocaine, this would potentially lead to something like methemoglobinemia. There have been studies and analyses of seized drugs that show adulterants present in a particular drug supply. For instance, out of Brazil, there have been numerous samples seized over the years and analyzed via a variety of different techniques, but with the goal of identifying, the adulterants in the samples. The top adulterants that I found in that particular study seem to be a mix, usually among lidocaine, caffeine, benzocaine, phenacetin, and levanosol. Now, benzocaine and phenacetin, which is an antipyretic / analgesic that is metabolized to paracetamol, both of them have been identified frequently in cocaine supplies and are both commonly associated with methemoglobinemia. Now, our patient's clinical picture with the elevated methemoglobin levels, hypoxia, CNS symptoms, kind of led us to believe that in the absence of other known methemoglobin inducers, that his drug supply had probably been adulterated with something like benzocaine. And though without formal identification of this substance, he didn't seem to have any other exposure. So we carried on with routine treatments for methemoglobinemia. Now, typical treatment of methemoglobinemia will consist of administration of methylene blue intravenously, usually in something like a 1 to 2 milligram per kilogram IV bolus over about 5 to 10 minutes. And then methylene blue will assist in the reduction of the methemoglobin, right, allowing ferric iron to become ferrous iron. And by serving as an intermediate in that enzymatic reaction involving NADPH methemoglobin reductase. And that reduction pathway will be activated and speed along the process of reduction in addition to the other enzymatic reaction involving cytochrome B5 reductase. Now, our patient responded quite well to a bolus of 1 milligram per kilogram of IV methylene blue over the 5 to 10 minutes. And he was subsequently administered oxygen. His met hemoglobin fraction had gone from 45% to undetectable within a matter of hours. But we know that in some instances, such as G6PD deficiency or pregnancy, there may be contraindications or even potential harm with the use of methylene blue. So what would we pursue in that case? And that brought us to our what if question. What if methylene blue wouldn't have worked in our patient? What if he had a contraindication to receiving methemoglobinemia? What are the alternative treatments for methemoglobinemia and what is the evidence? So our journal club today is going to focus on alternative and adjunctive treatments in methemoglobinemia.
Yeah, why don't we just keep plowing along at this point?
Sure, great, works for us. So I'm Laura Roper. I'll be presenting the first article on ascorbic acid for the treatment of methemoglobinemia, the experience of a large tertiary care pediatric hospital. So some background on this, previous studies on ascorbic acid. So it has been studied for a long period of time, and it's known that ascorbic acid reduces the hemoglobin molecule in vitro. And it is known that it does this faster than it would without any treatment. However, it requires high concentrations. One particular study that was referenced in our article today requires 10 millimoles of ascorbate. And just to give a sense, that's 1,000 times more than methylene blue, like a comparison like to other in vitro study that we'll be discussing later. In addition, it's also known that it's not as fast as methylene blue. There was a study done in dogs like in the 1940s that showed that it was slower than methylene blue. And also it only reduced the half-life by a factor of 1 to 2 compared to like control, no treatment. And then it compared to methylene blue, which had a 6 to 11-fold effect on the half-life. So kind of going into this, that's why ascorbic acid is not considered to be first-line treatment. Like Dr. Cates was saying, really methylene blue is first line. In addition, it's also known that ascorbic acid is not going to be effective orally for this. It doesn't reach the high levels of concentration that you need to treat methemoglobinemia. Really IV is what you need to reach because that's dosed in a dose-dependent manner. You can get up to that higher concentration, like the 9 or 10 millimoles that are seen to be effective in vitro studies. And really, if you give PO, you only get to like 200 micromole. As far as how to dose this, there's different things as far as background in this. Basically, they found there's proposals that you would need to get to that 10 millimole concentration, you need like 30 grams IV of vitamin C. By comparison, there are case reports that have shown success doing like 10 grams of Q6 in adults. Of course, our study is pediatrics, but the doses of mg per kg are very comparable to that. So just to give some sense on the background of dosing for methemoglobinemia. Lastly, the mechanism of how ascorbic acid does this is thought to be due to its antioxidant effects and a direct reducing agent. So it's thought to reduce the oxidant compounds, thereby decreasing the production of methemoglobin, as well as it also directly reduces the methemoglobin. But there's been further studies on that, and basically that is too slow to explain the mechanism alone. So that's why they think it's probably a dual mechanism there. And again, ascorbic acid is not considered to be first line because methylene blue is more effective. It's faster and it requires much less amount to work. And so the objective of the study today was to study 5 cases in children with acquired methemoglobinemia who were successfully treated with ascorbic acid. So the methods of this paper, it's a retrospective chart review. And the charts were done at a pediatric hospital in Argentina. They were identified using the ICD-9 code for methemoglobin anemia. Just the background, one case was caused by dapsone, which we're familiar with as a cause. One was unknown. They were not able to identify, kind of what Dr. Goldberger was saying, they weren't able to identify what the cause was. And 3 of the cases were attributed to nitrate contamination of water used to make their infant formula. And basically inclusion criteria for this, they had to have a methemoglobin above 2%. They also had to have signs of cyanosis and functional hypoxia. And They didn't specifically define functional hypoxia in the paper, but from what I could gather a little further on in the paper is that it seemed to include all the patients were tachycardic, 140 to 180. They all had some degree of respiratory distress, either tachypnea or intercostal retractions. And then one patient also had a normal anion gap metabolic acidosis. So those were like kind of the signs that they used of functional hypoxia. It was not a blinded study, of course. This is a retrospective chart review. They did have follow-up. They didn't specifically describe what that follow-up was, if it was all inpatient during their ED course. But they did say that they followed the patients over several days, and we'll kind of get into that in the results. So the results of this were that the dosing there is at the top. All of the patients got on day 1 IV of ascorbic acid, 1 to 2 grams. This would be based on the patient's kilogram weight. This would be equivalent to an adult. Like it's about 300 mg per kg. So that's equivalent to like a 30-gram dose in an adult, like we had discussed as background dosing before. So these are higher doses of vitamin C. And it was given diluted 1-to-1 with normal saline and administered over 10 minutes. And then basically the first day, like I said, it was IV dosing as listed there, and then they gave PO the other days following. Basically, all of the patients had clinically improved after 24 hours. And as you can see there, they listed all the methemoglobin level after 24 hours of treatment. All patients made a full recovery. They did not have any side effects from this dosing of vitamin C. Kind of, we'll get into that in the next slide, but some things that we're concerned about in the high dose vitamin C are renal injury is one thing, and the hemolysis, but they did not see any of that in their patients. And also, none of the patients had any additional episodes of cyanosis on follow-up. So they only required this dosing as listed. They didn't have any rebound methemoglobinemia noted. Unfortunately, again, with the limited case series here, retrospective chart review, there was no statistical analysis provided as far as like, statistical significance or risk ratios to discuss. So the conclusions from this paper that they drew is that methylene blue, if methylene blue is not available, and actually I did see that in my review of the literature quite often in other countries, may not apply to us here in the United States and where we practice, but Argentina is one place. Korea also listed that they do not have access to methylene blue in their ER. So in places where methylene blue is not available, this can be an alternative treatment option. I also thought this is interesting because, like, while it may not apply to us, where we practice most of the time is we have methylene blue available. I know that at least we had one case in residency where we ran out of methylene blue. So just, again, thinking about alternative treatments, I thought it was interesting from that perspective that this does seem to work. The second point that they made, I think, was more of future directions. They didn't really have any references or anything like that, but some other point that they proposed is, would this be better? Probably Dr. Cates had mentioned, we know that kind of a relative contraindication to methylene blue is G6PD deficiency. And, they brought up the point that maybe this would be better in, a better option in those patients. However, I will say I didn't think they really fleshed that out in the article. Doing my own limited research on it, I think that there's concern and that would have to be studied a little bit better. I can say that what goes in its favor is that in vitro studies have shown that it works in G6PD deficient patients, and G6PD is involved in the pathway that methylene blue induces to reduce. So that aspect is in its favor. However, in the same in vitro studies, they've shown that, like, as we know, G6PD deficient patients are at risk for oxidative stress, and ascorbic acid actually causes at these high doses oxidative stress in these patients. So I just think, again, that would have to be fleshed out a little bit more. Future directions I'd like to see is obviously a randomized controlled trial. This style of study, the retrospective chart review, cannot really prove effectiveness of a treatment. And so really that's what we would need to say definitively that ascorbic acid is effective. The strengths of this study were that they had a well-defined objective and that they developed, explicit inclusion and exclusion criteria. Limitations is that, of course, it's only 5 patients, it's a small sample size. And again, this study is not powered or designed to provide reliable evidence on an intervention's effectiveness. We really need a randomized controlled trial to determine that. So those were our thoughts on this article, and I would love everyone else's thoughts as well.
Excellent. Very nice review. We've got some comments coming in on the chat. Yeah, I thought this paper was really quite interesting. As toxicologists, though, it's almost like we're comparing apples and oranges. Like for example, in patient E, where the effect is, the exposure was nitrites, water, and diarrhea. So like definitely totally different than, than a case of clear methemoglobin inducing toxin. So really quite different. And then also like that methemoglobin did not go down. Patient D was the one, there was nitrites in water that, that one did drop. So I'm still very confused about the efficacy overall. I see, let's just read a few of the comments here from Wash U. Drop in methemoglobin report in the table is not impressive. Could expect that kind of decline with removal from exposure alone in a patient with an intact cytochrome B5 reductase activity. Absolutely. A and B minimal drops, E got worse, right? Exactly as we talked about there. And then, yeah, agree with, actually, folks can see what Kevin Osterhout had to say there. That is right. Yeah, it's a little bit unclear. Yeah, I guess kicking it back to you guys, I guess, the rate of reduction from ascorbic acid versus just what would be endogenous. Were you at all persuaded by this paper?
Think it's hard to say without having like any sense of like you guys kind of what you guys are saying, the statistical significance of it. Without having that comparison, it's really tough. I can say from other studies that it is weak, and so it's probably what we're seeing. Like I said, the one study I found in dogs was only like 1 to 2 times cut down in the half-life. So kind of what you guys are all seeing in these numbers, like how much of this is just endogenous versus the vitamin C contributing. I think it's kind of, I don't know if we can really tell that from this paper. I agree with everyone's assessment on that. And I think that there are other articles that kind of support that it probably helps it go a little bit faster, but not as fast as methylene blue.
Right, exactly. And also to Kevin's point that diarrheal babies, that it's going to just continue until that diarrhea is over. And I know we've gotten a number of these calls through our poison center where they'll just have this persistent methemoglobinemia. And what is ascorbic acid doing that point? Really a little bit unclear. Yeah, and again, if anyone would like to speak, just put your hand up. We'll be happy to recognize you as well. All right, great comments in the chat there. So I think it seems that we still would like to see some more controlled study to see the efficacy, how it compares to endogenous elimination. Fantastic. Okay, not seeing any hands. How about if we move ahead?
All right, so my name is Richard Chen. I'm going to be discussing the second and third articles. So the second article we'll be discussing is a comparison study between methylene blue, riboflavin, and N-acetylcysteine for the reduction of nitric oxide-induced methemoglobinemia. So the objective of this study is basically to compare the effectiveness of riboflavin, N-acetylcysteine, and methylene blue in reducing hemoglobinemia induced by nitric oxide. So the context of the study, they were looking, so nitric oxide obviously is not a common out of hospital exposure, but is often used as treatment in like cardiopulmonary bypass and cardiothoracic surgery. And so they were looking into seeing if these would be potential, which of these treatments would be potentially effective in helping prevent or minimize hemoglobinemia induced by that nitric oxide exposure. The study was an in vitro, prospective, non-randomized control study that was performed on 5 healthy volunteers. The specifics about the age and gender of these volunteers is not detailed in the paper. But they basically obtained blood samples from each of these 5 volunteers, and the samples were put into each of the 4 treatment arms of the control or normal saline, methylene blue, riboflavin, and N-acetylcysteine. They did some stuff with the culture and the solution that the erythrocytes were in to standardize like the glucose concentration, standardize the oxygen saturation, so that even though it's from 5 different individuals, that the samples were all, that some of those variables were controlled. So they essentially carried out 3 separate experiments. In the first experiment, they exposed the red blood cells to 320 parts per million of nitric oxide until they achieved a methemoglobinemia level of 16-18%. They then stopped that exposure and then put the 3 or 4 treatments of the control, normal saline, methylene blue, and riboflavin, and NAC into each of the solutions of erythrocytes. For each of the treatments, they tested 3 different concentrations, which they labeled as low, medium, and high concentration, which you can see from the slides there. And then they basically measured the decline of methemoglobinemia in the setting of those various treatments. The second experiment, they wanted to see how well the treatments inhibited the rise of methemoglobinemia under a continuous exposure of 32 parts per million of nitric oxide. So they took erythrocytes, put it under nitric oxide exposure, and then also put methylene blue and riboflavin into these dishes. And then they measured the rise of methemoglobinemia in the context of the continuous exposure. In the third experiment, they essentially combined the first 2 experiments. They first incubated the erythrocytes under 320 parts per million of nitric oxide, and then placed the erythrocytes under a continuous exposure of 80 parts per million of nitric oxide, and again measured the change in methemoglobin levels in the setting or after the treatments were placed into the solution of the erythrocytes. You'll note that experiment 2 and 3 do not include NAC. This is because of the results were equivocal to the control in experiment 1, so they decided not to test that treatment any further. So in terms of the results, these are sort of the overall results. In the first experiment, methylene blue was the most effective in reducing hemoglobin at all 3 concentrations that were tested. And they found that high concentration of riboflavin, or 120 micromoles, was also effective at reducing the degree of methemoglobinemia, although not to the same extent as methylene blue. And then they found that NAC was similar to the control and had no effect on the reduction. In experiment 2, they found that methylene blue at the what they called medium and high concentrations were effective in blunting formation of methemoglobinemia in the context of the continuous exposure, but the low concentration did not have as much of an effect, and that the high concentration of riboflavin also kind of had a similar blunting result. In the third experiment, they found that methylene blue, again at the medium and high concentrations, were effective in reducing the overall degree of methemoglobinemia, even under the continuous exposure. But at the low concentration, they did find that the rate of formation of methemoglobin was minimized and basically maintained a steady level of methemoglobin. Riboflavin did not have any effect at any of the concentrations that they tested. And as I mentioned, NAC was not tested in the second and third experiments because it was shown to be equivocal in the first to control. So just to go over some of the charts or the tables or graphs that were in the paper. So this first graph was just illustrating the comparison between the high concentration treatments. So control is illustrated by the open circles. Methylene blue at 10 micromoles, which is the high concentration, is illustrated by the solid circles. NAC. So the one thing that I wasn't able to clarify in the paper was in the graph, the way it was labeled, N-acetylcysteine was labeled as 10,000 micromoles, but the concentrations that were tested were 20, 200, and 2,000 micromoles. I'm not sure if this was a typo in the figure because they do not discuss this anywhere else in the paper. And then riboflavin is illustrated by the triangles of the solid triangles, which is 120 micromoles. And you can kind of see that methylene blue is clearly most effective in the reduction of methemoglobinemia, but you do see that there is a downtrend that is more significant as compared to the control or NAC. These graphs are the results from the second experiment, and you can kind of just see that they illustrate the results that I discussed before, that methylene blue was effective at reducing the rate of formation of methemoglobinemia at the medium and high concentrations, but did not have that much of an effect at the low concentration. And then riboflavin only at the high concentration did it have any effect, although the effect is, although statistically it was significant, the difference is not as stark when you actually plot it onto the graph. And then the final set of graphs, so these were for the third experiment. So this was the initial incubation of 320 parts per million of nitric oxide, followed by a continuous of 80 parts per million of nitric oxide. And so you can see that methylene blue again is effective at reducing the degree of methemoglobinemia, and then at the low concentration, you can see that the rate of change of the methemoglobin percentage is pretty much constant throughout the time measured. And then for riboflavin, under all three concentrations, the rate of reduction was equivocal to, and was not statistically significant compared to the control or normal saline. So concerning this study, overall, it illustrates that methylene blue still remains to be is the most effective way or treatment of methemoglobinemia, but it does suggest that riboflavin may be potentially beneficial, maybe not as a sole treatment, but maybe as an adjunctive treatment. I think the biggest limitation is that this is an in vitro study. So that the environment that the red blood cells are exposed to in vitro is definitely much different than exposed to in vivo and in the serum in an actual patient. And this also includes the concentration of these respective treatments that they would be exposed to is likely to be much lower as compared to being put in like a petri dish or in solution. The other limitation that these were healthy volunteers, which makes it, you can't directly translate apply these results necessarily to patients who come in who may be more ill, who have comorbidities. Although again, the paper did not go into detail about if these patients had any existing comorbidities. And the fact that NAC was not completely studied, I mean, based on the first experiment results, it's likely safe to assume that if it wasn't effective in the first experiment, that NAC would not be effective in the context of the second or third experiment. But that is still a limitation given that they did not fully investigate NAC as compared to the other treatments. And also the fact that nitric oxide was the inducing agent in this experiment. So again, nitric oxide is not something that people would typically come in as being exposed to, as this would be more in a hospital setting, likely in a surgical setting for patients who are on like cardiopulmonary bypass.
All right, excellent. That was a fascinating paper. And again, it's not, it's not in active patients, so it would be a big leap to extrapolate. What again, anyone would like to make some comments, please raise your hand, and also feel free to jump in the chat there. Just curious, what did you think about the riboflavin effect? Does that 120 micromole dose translate to anything that we can wrap our brains around clinically?
So it's that concentration for basically all these treatments for like the high concentration would be somewhere between around like 100 times higher than what you would typically see in like a normal person who had taken something like riboflavin. But I actually don't offhand know the amount that would be ingested that would kind of help kind of put that into perspective. But it would, this concentration, all the concentrations were sort of chosen as what would probably be higher than typical, what you would see normally in serum concentration for a person who receives like a treatment normally.
Great. Yeah, sorry, I didn't mean to put you on the spot, but yeah, so like, but to be clear, it would be a mega dose scenario if we
Correct.
try to do this
Correct.
clinically. So not ready for prime time at all. If someone gives a standard dose, we shouldn't really, be hard to expect that anything would happen.
Right,
Right.
exactly. And that's also part of the limitation of the fact that it was an in vitro study, that you can't see what kind of potential adverse effects that would result from giving these treatments at these kind of concentrations.
Right. And I did appreciate, that, it's great reading from authors outside of our specialty, because clearly there is a need for the nitrous in other clinical settings. It's great for us to be aware of that. So again, any other comments from the audience? I'm not seeing hands. All right, beautiful. Okay. All right, and then how about if we move on to the last article? And I hope we have, I see David Tannen's with us. I'm not sure if Steve Curry is, but yeah, let's go for it.
All right. All right, so the last paper that we're going to be discussing is titled "The Failure of Intravenous N-Acetylcysteine to Reduce Methemoglobin Produced by Sodium Nitrite in Human Volunteers," a randomized controlled trial. So this study, basically, the objective was to determine whether N-acetylcysteine, or NAC, was effective at reducing methemoglobinemia in human volunteers. This was a randomized, unblinded, controlled crossover trial with 9 subjects. And in this sense, the 9 subjects served as their own controls. The methemoglobin-inducing agent was sodium nitrate that was administered IV. And then each volunteer received either dextrose solution or NAC as their treatment. And then at least 1 week or more between when they got either treatment. So they would get one treatment and then at least wait at least 1 week and then receive the other, be put into the other arm for comparison purposes. So in terms of the exclusion criteria, they were detailed in the study. The test subjects were all male physician volunteers. They were aged 26 to 34 in good health. They did not include any volunteers who had known G6PD deficiency, any acute or chronic medical conditions, any history of hypersensitivity reactions to sodium nitrate or N-acetylcysteine, or use of any medications in the previous 2 weeks to when they were participating in the study. So in terms of the protocol for the study, NAC was dosed based on currently accepted standard treatment protocol. At that time, they had used the treatment protocol that was used in the United Kingdom. And so they started with a bolus of 150 mg per kg over 1 hour, which was followed then by a 14 mg per kg per hour infusion over 40 minutes. They then measured the methemoglobin levels at 0, 15, 30, 70, 90, 110, and 130 minutes, and then vital signs at those respective times on the slide. The sodium nitrite infusion was started at 0 minutes and then went to 10 minutes, and then the treatment was started at 30 minutes, which was 20 minutes after the nitrite infusion was stopped. So in terms of the results, they had, in terms of the baseline characteristics for each of the volunteers, the average hemoglobin in each treatment arm was 14.8. Baseline methemoglobin concentration prior to treatment with the sodium nitrite was 0.04 and 0.08 grams per deciliter, which works out to be somewhere like 0.2 to 0.3% in either arm. After the sodium nitrate infusion, the average methemoglobin at that time was 0.85 and 0.88 grams per deciliter, which worked out to be between 5 to 6%, or about 6%. And they essentially plotted all the data points for the methemoglobin levels and took the area under the curve to determine the effect on the methemoglobin concentration in these two treatment arms. And they found that the area under the curve was actually higher for N-acetylcysteine than for D5W, which was the control treatment. And from this, this indicates that NAC to some degree had actually decreased the rate of reduction of methemoglobin in these volunteers. This graph just illustrates that same data. And so note that the infusion of sodium nitrite was from 0 to 10 minutes. Treatment was started at 30 minutes. The top curve is the IV NAC treatment arm, and then the bottom curve is the D5W infusion arm. In terms of adverse effects or events, it was actually pretty common among this cohort. So that 6 of the 9 volunteers actually experienced some sort of adverse effect from the NAC. 3 developed facial flushing, pruritus, and cough. 3 developed nausea with emesis, although all 6 volunteers did go on to recover completely and did not suffer any permanent sequelae. One of the volunteers did drop out of the study because of they had some sensation of throat tightening. And so that was after they had received NAC. So I don't believe that patient underwent like the corresponding D5W. And then the D5W arm, no volunteers had suffered any adverse events from that. So in terms of conclusions from this study, so overall, the results showed that NAC is not effective in improving the reduction of methemoglobinemia, and it actually may worsen it to some extent. The difference was statistically significant, although there's a question of how clinically significant that result is. In terms of limitations, this is a small sample size. The volunteers, again, were healthy and they were all male. Of note, each patient also was pre-treated with acetaminophen prior to infusion to counteract the expected headache that would occur with the sodium nitrite infusion. So the effect on NAC's ability to reduce methemoglobin can't necessarily be discounted. And then again, this particular study used one specific agent, which was sodium nitrite, which is more likely to be run into for a patient coming out of hospital. So maybe potentially be a more applicable population. And then notably, the degree of adverse effects or events in this study was high, although there is some thought that the sodium nitrite had contributed to some of these adverse events.
All right, excellent. And we, let's see, we have David Tannen with us. And Steve Curry, if you're on the line, please unmute as well. So David, yeah, could you give us any insight? I enjoyed the chatter there. I've got to ask the obvious question. Why was it all men? Is this just to prove that women are the more intelligent of the sexes?
Just going back in time when it was easier to do all of one sex, whether it was in animals or people. Obviously, we've gotten away from that, but this was like 1998. I don't know if Steve joined, but we put together this study based on a previous in vitro study by Robert Wright, who showed that there was a difference with N-acetylcysteine for methemoglobinemia. Obviously, the concentrations they were able to get in vitro were much higher than what we were going to do in vivo. So we just used the in vivo that we were using for Tylenol overdose patients.
Great. And then if I understood correctly, so were you being infused over 15 minutes? Is that right?
With the NAC? Yeah, we did. Yeah. No, we actually did it. That's a great question. I'd have to look back at what the infusion rate was.
Yeah, because I enjoyed that part of the discussion about, I guess, in the hands of the authors that when given over that longer period of time, there's a much lower rate of anaphylactoid symptoms. And I remember that was an active discussion back then.
Right, and then, obviously for the fellows, back at that time, IV NAC was not an FDA-approved medication. So we took the PO NAC and ran it through like a 32 millipore filter and gave it IV. So it may have been, yeah, there may have been contaminants and other things in the solution that could have caused the anaphylactoid type of reaction.
How did this get IRB approval then? if we did?
We did.
Yeah, so from lots of reasons, it would have been difficult to get approval. For some reason back then, it was fairly easy.
Yeah, I think this generation of fellows are not having to experience, hey, we got a great fellow volunteer study. Let's go.
Well, I don't know if Steve is on the line, but at that time, it was pretty common that the fellows were also the volunteers in the study. So that's where you got people. We had other physicians who were rotated through our rotation, through the tox rotation, volunteered to do it. The one person who had I think a pretty significant anaphylactoid reaction was just he was another physician who had rotated through us in tox. And he obviously, everybody loves Steve. If Steve's not on, everybody loves Steve. So everybody was willing to volunteer in his studies.
That's priceless. We did a PO versus inhaled NAC study like around that period of time. And I could just tell you inhaled N-acetylcysteine was not pleasant. I don't recommend anyone else. Hey, there's a question in the chat here. What's the theory based on authors depending to run this study? Yeah, so could you just mention like what was the idea? Like what was the mechanism that NAC would work for methemoglobinemia?
Yeah, I mean, just like what was, honestly, there were, I think, 2 in vitro studies out at that point that had showed that probably the sulfur group may help reduce the ferric ion to a ferrous state. And at least at higher concentrations in the previous in vitro papers, it seemed interesting. And just like the fellows mentioned today, it was methylene blue was what we used as our standard of care then. But if for whatever reason people were G6PD deficient, or at that time dapsone was widely available, so there were reasons that we were looking for possible alternative infusions, just like you mentioned. So based on that sort of previous studies and the fact that it had we think we knew how NAC worked, that it had the available sulfur group that could help reduce things, that it may help with methemoglobinemia. A few years later, I tried an in vitro study using sodium thiosulfate, kind of with the same idea. It didn't do anything.
Great. And then, also the dosing ranges that you guys hit in the study, do you have any reason to think at high doses that there'd be an effect, or have in your mind you just closed the book on this as a concept?
No, it's a great question. So, just based on the in vitro, it may actually be at high doses that you would get more of a bang for your buck. It's just, especially at the time when we did worry about anaphylactoid reactions and just, higher infusions of NAC, how high do you go? So we were basing it off of a therapy that was already being used, right? And people have asked with the IRB considerations, it's a lot easier to go in front of an IRB saying that I'm using a standard protocol that's already in place for something else that we treat. And in Phoenix, even though it wasn't FDA approved for IV NAC at that point, as Steve wrote in the paper, he had been using it since 1984. So it had been well established. I think I did this study in 1998. So it had already been like the established therapy for over 14 years at that institution.
Yeah, very, very interesting. Interesting comments in the chat as well. And yeah, I was a little surprised about the rate of side effect in your study, because we were doing the same thing. We were using the PO through a filter and giving it intravenously and having folks sign consent. And it was very cumbersome at the bedside for people with persistent vomiting. and we went through a lot of machinations to try to get the PO down. It's good that that's how to do. But I guess in our experience, we also found a very low rate of anaphylactoid reaction. So I do find that that's interesting.
So obviously we did too, and in our Tylenol toxic patients or Tylenol overdose patients, we almost never saw anaphylactic reactions. So we didn't know if it was something that maybe a priming of the pump, the sodium nitrite, may have primed the pump to have these anaphylactic. We wrote a little thing about it, but we thought maybe it was a combination of the two, or that somehow if you have acetaminophen that's being metabolized, that would be protective when you have NAC. But that was similar to our experience, was that in our acetaminophen overdose patients, we almost never saw anaphylactoid reactions. But in this, almost everybody had some type of reaction. You know, we said 6 out of 9. That was when people actually told us they were itchy. And I was one of the subjects, and I got itchy and I had a cough and it was uncomfortable.
Yeah. Yeah, those volunteer fellows may not have said anything. Who knows?
Right.
All right, excellent. And again, any questions, please, let's see some hands if anyone would like to say anything. But no, that's great. All right, well, yeah, thanks, David. Really appreciate you getting on the line. It's great to hear from one of the authors from a paper that's already, you know, it's been out there a while, but also very relevant. I know we are definitely looking for these alternate ways to approach methemoglobinemia when we don't know about G6PD deficiency, et cetera. Great. So, Einstein Group, do you guys have any wrap-up comments?
I think just like overall, I think what we found so like through like these 3 articles and sort of other articles that we had also reviewed, there isn't a definite good answer or alternative to methylene blue. Methylene blue still remains king in terms of the treatment first line choice for treatment of methemoglobinemia. And I mean, there's some promise in some of these agents, but I don't think the evidence is there to be able to knock methylene blue off its throne.
Agreed. All right. Okay. Well, I think we've run the cycle here. This is great. Thank you so much for doing this. These were really interesting papers. Great discussion. David, thanks for calling in as well. Our next edition of National Journal Club will be May 11th, and will be presented by Gina Jacob and the folks at Rutgers. So we're looking forward to that. So thanks again so much, everyone, and we will see you next time.